So today I am presenting history of a case of oral cancer. Should I start, sir?
Yes, please.
Please carry on.
Thank you, sir. So I am presenting history of a 59-year-old male resident of Bhagalpur, Bihar, laborer by occupation, presented with chief complaints of non-healing ulcer of left cheek inside mouth since 3 months, pain in the ulcer since 15 days. History of present illness. Patient was apparently asymptomatic 3 months back. Then he noticed an ulcer on left side of cheek inside mouth while brushing, which was insidious in onset, gradually progressive. It was approximately 1.5 into 1 centimeter initially to present size of approximately 4.5 into 3 centimeters. Patient took treatment at village level, but it not helped. From last 15 days, patient developed pain at the ulcer site, which is aggravated by chewing solid foods, having spicy food, and relieved by taking analgesics. There is no history of excessive salivation, reduced mouth opening, pain radiating to ear, no history of change in voice, difficulty in swallowing, sharp teeth, ill-fitting denture, neck swelling, no history of significant loss of weight, loss of appetite, and there is no history of cough, hemoptysis, or bone pain. Past history, there is no medical comorbidities associated. History of road traffic accident resulting in injury at the left forehead is there, for which skin suturing was done at PHC hospital, and it was 15 years back. History of multiple tooth extractions over a span of 6 years in view of tooth infection and loosening is there, though no record is available. No history suggestive of radiation exposure to head and neck. Personal history. Patient is low socioeconomic status, married, chewed tobacco for 40 years, then quit 3 months back, non-smoker, regular alcohol user, used to drink 1 per week and on an average 250 ml per week for 20 years, quit 3 months back. Mixed diet, normal sleep cycle, normal bowel and bladder habits, no history of high-risk sexual behavior, no history of allergy to any drug or product. Family history, there is no history of cancer or related death in family. Summary of history, 59-year-old male having low socioeconomic status, reformed tobacco chewer and alcohol user, non-smoker, presented with complaint of non-healing progressive ulcer on left cheek inside mouth since 3 months, associated with pain from last 15 days, with history of multiple tooth extractions over a span of 6 years. Should I proceed with examination, sir?
Just hold on. Sir, Dr. Pradhan.
Tell me, why did you ask for this history of high risk sexual behavior?
Sir, the history of high risk sexual behavior have particular importance in CA oropharynx because of the infection by high risk types of HPV virus, human papilloma virus. But cases like 15 to 25% cases of CA oral cavity also have association with HPV, though its resultant primary in oropharynx or like that.
Okay. It's mainly for the oropharyngeal cancers.
Sorry, sir?
It's mainly for the oropharyngeal cancers. You need to know that.
Yes, sir.
Okay.
How does alcohol act in oral cancer? You said alcohol, history
Yes,
of
sir.
alcohol.
So, sir, alcohol basically acts in many ways. Like it is itself an irritant, so it can damage the mucosal barrier of the mouth, and then it also acts in collaboration with the other risk factors like tobacco, and also with in presence of poor hygiene, there are commensals which can convert alcohol into acetaldehyde, which is known to level 1 carcinogen. Then this acetaldehyde can lead to carcinogenesis.
Okay. Alcohol actually increases the cellular permeability of other tobacco carcinogens through mucosa. Okay.
Okay, sir.
So it is acting in conjunction with other carcinogens present in tobacco or other food items. And of course, you said metabolite of ethanol is acetaldehyde, which has got a locally damaging effect. And then alcohol also decreases the activity of DNA repair enzymes with increased chromosomal damage. Okay.
Okay, sir.
So, of course, it has got effect on immunity, reduction in T cell number, decreasing mitogenic activity of, these are all basic science answers. And the effect on calories causing liver damage, these are all indirect effects of alcohol. And then any history of ear pain, did you mention?
Yes, sir.
So how does the ear pain occur in oral cancer? Some examiner might ask you.
So in oral cavity, the sensations are taken like efferent nerves are buccal nerve, inferior alveolar nerve, and lingual nerve.
Buccal nerve.
Yes, sir.
We are talking
From
of tongue cancer, no?
No, sir, buccal mucosa.
Buccal mucosa, okay.
Yes. So these are the efferent nerves, and the efferent is auriculotemporal nerve, which carries sensation from the external auditory canal and the tympanic membrane anterior half. So because of this innervation, there can be referred pain in the ear also from the primary or some lesion in the oral cavity.
So you should know that which nerves will convey the pain fibers from oral cavity, oropharynx, and hypopharynx. They are all different. Okay?
Yes, yes, sir.
Well, some examiner might ask you, tell us the pain pathways.
Okay.
So they are different for three.
Yes, sir. So
common familiar question is the smoking history. If somebody, of course, this patient doesn't give, but how do you measure the smoking history?
smoking history is measured by the PEC index here, sir. Like patient packs of cigarette or BD patient having per day into use of years.
So this you should know how to present an exam.
Yes,
sir. Dr. Pradhan, anything in the history?
No. Okay.
Okay.
General physical examination. So all examinations performed in well-lit room with proper exposure after taking informed consent of patient. Patient is conscious, oriented to time, place, person. Average built and nourished, well hydrated. ECOG 1. Pulse 85 beats per minute, right radial artery, regular, volumic. BP 130 by 84 mm Hg, right arm supine position. Height was 1.65 meters, weight 56 kg, and BMI is 20.57 kg per meter square. There is no pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy, and edema. Before I start examination, just clinical pictures. So local examination, inspection.
Can we just wait at local this general physical examination?
Yes.
All right, this patient has come to you in the clinic, but when you are practicing, you should see so many things. Maybe the patient is coming on wheelchair. Maybe the patient is in trolley or walking with the water bottle in his hand. He might have received radiation. Maybe he's carrying an hanky or some spittoon. He's got excessive salivation. He's got some obvious swelling on face, or his eyes are closed because of swelling. So maybe you get an exam some advanced case of oral cancer with all these situations. So remember to mention the appearance of a patient as soon as he enters.
Okay.
As soon as you are introduced to that patient in exam. Okay?
Okay.
तो ये नहीं कि पेशेंट लेटा हुआ है तो मेरे को यही चीज बतानी है, तो और जो एडिटिव इफेक्ट्स हैं वो भी जरूर बताने चाहिए.
Okay.
इन एग्जाम. ओके.
Okay.
चलिए.
So local examination, inspection, mouth opening approximately 5 centimeters, nicotine stains present over teeth, halitosis present, poor oral hygiene, multiple teeth missing in left lower jaw from first to sixth, right lower jaw, last two molars, and left upper jaw missing teeth 1 and 2. Ulceroproliferative growth noted on left buccal mucosa, approximately 4.5 centimeter into 2.5 centimeter, with irregular rolled out margins and base covered with slough at parts. Anteriorly, approximately 2 centimeters short from the right lower incisor. Posteriorly, it is up to the last molar tooth. Superiorly, approximately 1.5 centimeter from the left upper gingiobuccal sulcus. Inferiorly, abutting the left lower edentulous alveolus and reaching intraorally up to 5 mm of left angle of mouth with nodularity and fullness of adjoining skin of cheek, approximately 2.5 into 2 centimeters. Rest of oral subsides appears normal on inspection. No visible fullness, swelling in bilateral neck.
Doctor, just make a correction here.
Sir.
You have written 2 centimeters short from right lower incisor.
Yes, sir.
We are discussing left or right?
Sir, the patient was missing left side all tooth except the molar, so I measured from the right first incisor.
I didn't get your point. Anteriorly, approximately 2 centimeters short from right lower incisors.
Yes, sir. So the patient was missing teeth on left side, sir, from 1 to 6. So I had no fixed landmark there. So I used the first right side lower first incisor as a landmark.
The lesion is on left side.
Yes, sir.
Lesion को describe करने के लिए ये कैसे right lower incisor? How can it help you in?
So, sir, there was no teeth on left side from first to 6. So I took this as landmarks. Right lower first incisor.
अच्छा, ठीक, चलिए.
Do you call this an ulceroproliferative or would you call it an ulceroinfiltrative?
Sir, ulceroproliferative growth, sir.
What are the morphological types of ulcers?
Sir, ulcer can be ulceroproliferative, ulceroinfiltrative, or just infiltrative. Sir.
Just infiltrative. Achha.
Yes.
Anything else?
It can be, sir, ulcerated, ulceroproliferated, ulceroinfiltrated, and infiltrated morphological.
Anything else? Verrucous forms by?
Yes, sir. Verrucous.
Verrucous are easily identifiable. झाड़ी की तरह दिखते हैं, हाँ?
Yes, sir.
आपके वहां पर तो बहुत ज्यादा हैं. बिहार में तो verrucous carcinoma is very
yes,
common.
Sir. Yes, sir.
And sir is asking what type of lesion is this? Ulcerated,
yes,
ulceroproliferative.
Sir, ulceroproliferative as the growth is protruded over the cell.
Okay, I'll buy that.
Okay.
Sir, आप कुछ कह रहे थे? Sir, we can't hear you.
I would call this an ulceroinfiltrative because it has really gone right up to the skin. It is more infiltrative than, it's not an ulceroproliferative growth is one that is really exophatic. But by the bulk of the tumor, you will see the bulk thing, but it is, if you see the center core of the tumor, you can see that it is excavating almost up to the skin here. Whereas an ulceroproliferative growth is just a proliferation which is ulcerated. but you can literally lift the cheek skin up. That is ulceroproliferative. But when it is an excavating ulcer, then it's an ulceroinfiltrative. But it's okay. Let's not go into the semantics. You can continue.
Okay, sir. Thank you.
Carry on.
So before palpation, as we can see in this picture, when we started the palpation, the growth was not abutting the alveolus, while on inspection it was looking like it is abutting. So on palpation we confirmed the inspectory findings, and it was non-tender.
Go back to inspection.
Sir.
Inspection. In exam, just remember, don't start with mouth opening straight away.
Okay.
Look at the face of the patient.
Okay.
Okay. Look at the face of the patient. You are showing us a lesion in near left angle of mouth.
Yes, sir.
So as soon as you see a patient, has he got swelling on one side? His nasolabial fold, is it obliterated? Is there any swelling in the infrazygomatic area or below the zygoma, means before the eye, below the eye? The swelling is obvious. So start describing the facial expressions of a patient.
Okay.
Okay. Don't just jump on mouth opening is 5 centimeter and nicotine stains are present. Has he got submucous fibrosis? Has he got other leukoplakic patches or erythroplakic patches in the mouth?
No, sir.
तो वो mention करना चाहिए भाई.
Okay. So I wrote like appears to be normal, so I should mention all these terms like.
You see, you should be able to बेसिकली जब ये डिस्क्राइब कर रहे हैं ना, उसमें सारी चीजें पहले आ जानी चाहिए.
ओके.
Facial expression is something, first thing which should appear in exam.
Okay.
चलिए.
So inspectory findings confirmed: non-tender febrile by touch, mouth opening 5 centimeters, ulceroproliferative growth of 5 into 3 centimeter on left buccal mucosa with irregular rolled out margins and base covered with sloughed parts, anteriorly 2 centimeters short from the right lower first incisor, posteriorly up to last lower molar tooth. Superiorly it was 2 centimeters from the left upper gingivobuccal sulcus, inferiorly 5 mm from the left lower gingivobuccal sulcus, intraorally reaching up to 5 mm of left angle of mouth, in duration of the left angle of mouth with non-pinchable adjoining skin of cheek around 3 into 2 centimeters. There is no active bleeding or discharge. Right lower first and teeth loosening present. No sharp tooth. Rest oral subsides normal. In neck, there is no palpable lymphadenopathy in bilateral neck. Systemic examination were normal. Summary: 59-year-old male having low socioeconomic status, reformed tobacco chewer and alcohol user, non-smoker, presented with complaint of non-healing progressive ulcer on left cheek, inside mouth since 3 months, associated with pain from last 15 days, with history of multiple tooth extractions over a span of 6 years. Patient having 5 centimeters mouth opening with nicotine stain, halitosis, poor oral hygiene, missing multiple teeth of both jaws, with loosening of right lower first and second teeth, along with ulceroproliferative growth of 5 into 3 centimeters on left buccal mucosa with irregular rolled out margins, base covered with sloughed parts, anteriorly 2 centimeters from right lower first incisor, posteriorly up to left last molar tooth, superiorly 2 centimeters from left upper gingivobuccal sulcus, inferiorly 5 mm from the left lower gingivobuccal sulcus. Intraorally, it is reaching up to 5 mm of left angle of mouth, in duration of left angle of mouth with non-pinchable adjoining skin of cheek 3 into 2 centimeters. No palpable lymphadenopathy in bilateral neck.
Sir?
What is halitosis, Rakesh?
Sir, halitosis is like bad smell coming out of mouth of patient due to poor oral hygiene.
And he doesn't have excessive salivation, is it? You said?
Patient told he is not having excessive saliva.
Is the retromolar region involved?
So retromolar region on palpation, it was just the tumor was just reaching to the behind the third molar, and it was as such not inwards clinically.
Lower or upper?
Lower.
Dr. Rakesh,
Yes, sir.
you said 2 centimeter away from the upper sulcus. Am I right?
Yes, sir. From upper.
And 5 millimeter from the lower sulcus.
Yes, sir.
If you talk of prognostication, which one is bad? The upper sulcus or involvement or the lower sulcus involvement?
Sir, lower sulcus involvement
is bad.
Yes, sir.
Why?
Because in lower sulcus, the surgery will require segmental mandibulectomy, which is more extensive surgery compared to removing part of alveolus, upper alveolus.
And upper sulcus, if it is involved,
then we will need alveolectomy or max to max or infrastructure maxillectomy, which can be better taken care with obturator, only obturator also.
Rakesh, you see so many cases. I think the maximum number of oral cancer, especially cheek, you see.
Yes, sir.
You see, upper sulcus is worse than the lower sulcus. Lower sulcus, you can remove the disease, skin involvement, mandible involvement, but upper sulcus, what happens? The disease first goes into the soft tissue areas which are infratemporal fossa. Okay. The involvement of upper alveolus is very late. First involvement is soft tissues in ITF. So you need to clear the ITF rather than doing a maxillectomy. Maxillectomy की requirement तो बड़ी late होती है. So biologically, the soft tissue involvement in upper sulcus is actually a poorer prognosis than the lower sulcus involvement, where you may not get the clearance in upper sulcus area.
Okay.
Yeah.
Okay.
What is anterior and inferior is better than what is posterior and superior. You have to remember that. In the oral cavity, what is posterior and superior has much worse prognosis than what is anterior and inferior.
Okay.
Very good point made, Dr. Diwan. So now what will you do for him?
और राकेश ये बताना आपने जो no palpable lymphadenopathy in bilateral neck.
Yes.
Don't say this thing in exam.
Okay.
Okay. Lymph nodes are always there, especially submandibular nodes. So soft lymph node, mention any positive finding in neck, you may say appears to be reactive.
Okay.
And it is better to say no suspicious lymph node enlargement in neck.
Okay.
Okay, rather than saying no palpable lymphadenopathy in bilateral neck. और दूसरी चीज मैंने स्टूडेंट्स को देखा है कि वो डिस्क्राइब करते हैं 3 centimeter lymph node at level 2 felt. So in exam, never mention in clinical examination levels. Always name the level, not the level, name the site. Say submandibular node is present. You should mention submandibular node, this much size, fixed or not fixed, tender, not tender, overlying skin is involved or not involved. And then jugulodigastric node is palpable rather than saying level 2 is involved. Okay. So exam में site of lymph node mention करना चाहिए. rather than the level of lymph nodes.
Okay, sir.
So don't forget that.
Okay, sir.
Chali. Sir, can we allow him to proceed? Can he proceed?
Yes.
Rakesh, proceed.
Thank you, sir. So, based on history and clinical examination, my provisional diagnosis is malignant lesion of left buccal mucosa, clinical T4A N0 MX. Now, we will proceed for diagnostic workup.
Any comorbidities he has?
No, sir.
Okay.
So, for diagnostic workup, we did biopsy first, and it turned out to be squamous cell carcinoma grade 2.
So what is the difference between T4A and T4B? What is T4B?
T4B is very advanced oral cavity cancers, including invasion up to the pterygoid plate, skull base, masticator space, and encasing the carotids.
How much is encasement of carotids?
Sir, more than 180 degree.
More than 180 or even more?
Like 270, even 270 to 360 degrees will be more towards.
Anything else which comes in T4B?
Sir, involvement of pterygoid plates, skull base, masticator space.
That you said.
Yes, sir.
Say there is foramen ovale enlargement.
Yes, sir.
MRI says foramen ovale is enlarged.
Yes, sir.
So what will be the stage?
It will be T4B. Sir.
T4B.
Yes, sir.
Prevertebral fascia involvement.
It will be T4B. Prevertebral.
Mention karna chahiye. Examiners are very fond of asking what is T4B, what is unresectable. Okay, you should also know what is the difference between unresectability and inoperability. Okay?
Okay, sir.
Chali.
So, for staging workup, we did CCT face and neck with NCCT thorax, and these are the images. So, as we here, if we move from caudal to cranial, we can see that there is this heterogeneous mass appearing starting appearing here, but as the patient was not having not having multiple teeth, and there was also infiltration of angle of mouth, he was not able to hold enough puff of air in his mouth, so puff cheek view was not able to be done, and because of that only we can see that there is heterogeneous mass abutting the left side of mandible. Some necrosis is also there, and it is obliterating the buccal space reaching up to the skin. As we further move up, we can see it is moving, just reaching up to the RMT area, and when we further see, there is no further involvement by the growth. Here we can see that the ITF area and masticator space seems to be free. In the coronal view, same findings were noted. We can see this is the growth which is involving the left side and infiltrating the buccal space as well. And there is.
Rakesh, if you want to explain in future for all residents,
Yes,
show just one picture at a time rather than showing 20 films and you can't make out anything.
Okay, sir.
Yeah. Just one spot and then show, then describe.
Okay, sir.
So
Sure.
investigation is better in which situation of oral cancer, MRI or CT scan?
Sorry, sir.
Which investigation is better for oral cancer assessment, MRI or CT scan?
Or it will depend on the subsite involved, sir. Or oral cavity proper. Sir?
Suppose it is tongue.
For tongue, MRI is better.
So which are the situations where you will prefer MRI than CT scan in oral cancer?
So when there is the mostly as a rule, if there is involvement of oral cavity proper, that is tongue, floor of mouth, primaries, we will prefer MRI more. And if it is buccal mucosa or RMT region or lip,
Just tell me the indications of MRI in oral cancer.
indication CA tongue and floor of mouth, sir.
And if you want to evaluate the skull base,
Yes,
if you want to see the foramina,
yes,
if
sir.
you want to assess the marrow,
Yes, sir.
MR is better. Okay.
Yes, sir.
And all other sites,
All
they
other
are
sites.
equal, and depending on what you have, you can do
Yes,
anything.
Yes, sir.
So in this, can you show us the mesenteric space and the ITF and tell us which is more important for us as surgeons? With your cursor, you show us the mesenteric space.
Is my cursor visible, sir?
Yes.
So this is the area. Here we can see the both pterygoid plates and the notch area. So here we can see it is probably the lateral and medial pterygoids. This is the masseter muscle, and part of temporalis muscle is seen there. So if we take this whole as a compartment, including the all the masticatory muscles, including masseter, lateral pterygoid, medial pterygoid, all of this makes the masticator space. While in ITF we leave this the mandible only forms the lateral boundary, so we leave masseter out of the inclusion, and we include only pterygoids with some part of the pre-styloid area in the ITF. And from point of view of surgery, the ITF is more important, as high ITF cases are in like very advanced, considered very advanced cases, and they are not convertible into resectability most of times.
But for the surgeon, both are important.
Sir?
For the surgeon, both are important.
Yes.
ITF, of course, because it makes the lesion unresectable, particularly if the high ITF is involved. But the masticator space is also important. Time and again, these radiologists will report that the terminal fibers of the temporalis is involved. And you've got to be extra careful when you're doing the mandibulectomy to see that you get additional margin or cuff of temporalis muscle. So
Yes.
for surgeons, both are important. One for non-resectability and the other one for making sure that you include that muscle into the resection.
Okay.
Exam में they might ask you, you should know the boundaries of mesenteric space, boundaries of infratemporal fossa, contents, and what is their significance.
Okay.
Then muscles of expression, and say I'm very fond of asking how will you test the function of medial pterygoid and how will you test the function of lateral pterygoid? Can you tell me?
Sir, lateral pterygoids basically helps in opening of mouth and protraction of mouth, and lateral pterygoids move the mandible side by side, while medial pterygoids are involved, have the action of elevation of mandible.
Yes. Elevation is, I'll just put my, so medial pterygoid, the direction is like this. So they will elevate, this is the function. And direction of lateral pterygoid is like this. So forward protrusion will be by lateral pterygoid. Okay?
Okay.
So you should know when will you call the lesion as unresectable. Suppose a patient has got some planes with lateral pterygoid are lost. Will it be unresectable or resectable?
So lateral pterygoid is part of high ITF, sir. It will be by borderline resectable case or
No, not borderline. This is unresectable.
Resectable.
Okay.
Yes.
ठीक है. तो
Yes.
ये आपको एग्जाम में ध्यान रखना है.
जी sir.
Sir, can we proceed? Can you proceed?
Yes, yes, doctor.
Rakesh,
Yes.
do you have any more slides?
Sir, this is the end of slide, sir.
Okay. So we can go on to discussion.
So now after all this radiology, what is your final staging?
It is, sir, T4, A, N0, and MX, and M0.
And what is your plan now?
So this is, we will plan, we will give the patient all the options after PSC workup, and first priority will be surgery. So we will plan for surgeries.
What surgery will that be?
It will be, sir, composite resection, including the primary, the involved part of skin, along with the neck dissection and reconstruction. And as in the lower GBS, the disease was closed, but when discussed and patient was having loss of multiple tooth, but still the vestibule was having adequate height. So our board planned for marginal mandibulectomy as for getting negative margins in the lower aspect. So all plan will be composite resection, including marginal mandibulectomy plus left selective neck dissection and reconstruction.
What type of reconstruction you are planning?
We can give option of both type of reconstructions in such cases, sir, as the disease is involving part of skin and its extensive bulk is going to be removed. We can give option of free flap also, and regional flap like PMMC will also do good in such cases.
How will you counsel the patient? Say this patient, what all will you tell him?
So first, I will tell the patient about the diagnosis, that is, it is a case of malignancy. I will counsel him, and we will start the prehabilitation also along with that.
Only malignancy, or he has got locally advanced disease?
Locally advanced disease, and prognosis will be definitely lower in such cases, but still surgery gives the best available option along with the needed adjuvant treatment. So we will counsel about that, and then what functional liabilities or it surgery and the adjuvant treatment can lead to in future, and how it can be coped up. We will also counsel the patient about that, so he is ready for the continue throughout the line.
That is all.
And we will also counsel him about possibility of recurrence in such cases in future.
Extent of surgery आप बताएंगे, प्री एनेस्थेटिक असेसमेंट क्या आप बताएंगे, अल्कोहल या स्मोकिंग जो भी अगर ले रहा है उसके एब्स्टिनेंस के बारे में बताएंगे, चेंज इन लाइफस्टाइल्स यू शुड टेल हिम बिफोर हैंड. ये तो नहीं है ना कि कोई हैवी अल्कोहलिक है और आपने आज एडमिट करके कल भर्ती कर दिया, ऐसा नहीं होता.
Yes.
What is the age of this patient?
59 years old.
So maybe cardiac assessment if it is such a major surgery.
Yes, sir.
What is prehabilitation?
So prehabilitation is basically making the patient ready for any major event like major surgery. In this we do we'll check the nourishment, and we will give the optimally required nutritional requirements we will complete. Then we will do the preoperative cardiac optimization and strengthening or lung exercise for good, to able to tolerate such extensive surgeries as well GA. And we will also control if he is having some diabetes and like that, then glycemic control will be also part of rehabilitation.
Actually, it is nowadays not just concept of pre-anesthesia checkup. In addition to PAC, you make the patient see a chest physiotherapist, speech and swallowing therapist, nutritionist, maybe for dental hygiene. So all those things the person should, and physician for diabetes, all these things should be settled before you actually put the patient on OT table. Okay?
Yes, sir.
ERAS protocol क्या होता है सर्जरी में?
ERAS protocol is enhanced recovery after surgery, sir. So this all this is divided into three parts: pre-operative, intra-op, and post-operative parts. So in pre-operative part, it will include the rehabilitation along with the multidisciplinary opinion like nutritionist and speech therapist, physiotherapist.
So anyway, you should know about the ERAS protocol for different type of cancers, and head and neck has got specific requirements. So you should know in exam. Okay?
Okay, sir.
अब सर से पूछिए क्या? Sir,
yes, Rakesh, you tell me about you said you're going to do a full thickness cheek excision, isn't it?
Yes, sir.
What will be your margins?
So margins unstretched 1 centimeter all around the tumor.
And for that, you think you will have to do a marginal mandibulectomy, is it?
Yes, sir.
It's coming very close to the sulcus.
Yes, sir. Lower GBS is just 5 mm away.
Okay. What is the bone is not involved here? Prognosis wise, which is worse, bone or soft tissue?
Soft tissues.
Yes. And there are studies for that. Do you know of any of these studies that have really studied this part? That in oral cancer, gingival buccal cancer, in the resections, which part is carrying a greater worse prognosis? Soft tissue.
Soft tissues are like as told by sir also previously, that posterior superior lesions going to ITF, these, and also pattern of invasion also matter, like worst pattern of invasion in soft tissue. These all things also matter.
You mentioned that you will do one of the options for reconstruction is a pectoral myocutaneous flap.
Yes.
Is it easy to do a full thickness cheek excision, leave the mandible in there, and do a reconstruction with a pectoral myocutaneous flap bipaddled? Is that easy?
Sir, depending on the extent, as if the extent is going to be more and on our marking we feel that it is not going to fill up the defect, then we can consider free flap. But mostly pectoralis myocutaneous flap meets the requirements, sir.
It's not only the size, but for that whole pedicle to go over the mandible and be turned on itself. In very few cases, you'll be able to do that. In muscular people, 100% you will not be able to do. In very frail individual with very thin muscle, you may be able to bipaddle a cheek defect with the mandible intact. At one time, before the advent of the free flaps, reconstruction of full thickness cheek defect with the mandible intact was one of the greatest challenges for the head and neck surgeon or the plastic surgeon, just like circumferential pharyngectomy used to be. So very, very few cases will you really be able to do a full thickness cheek defect with an intact mandible, repairing it with a pectoral myocutaneous flap bipaddle. It's not feasible. I'm not talking of just the size of the lining and the cover, but to bipedal it and put it over the mandible is asking for trouble. If the mandible is resected, yes, you can. I don't know, Dr. Diwan, what do you feel about it?
I fully agree, sir. As a DNB student, I think you should know that if you do not have the facility of free flap, means you don't have the reconstructive surgeon with you and you are going to do it, best is to do segmental mandibulectomy and then proceed with bipedal PMMC. Otherwise, bipedal folded on itself becomes so bulky and it will not be possible to put it over the intact mandible. Okay?
Okay, sir.
And otherwise, if you are doing marginal, be ready that you are going to proceed with bipedal free flap.
Okay.
Have you seen a bipedal free flap?
Yes, sir.
Okay. In your institution, you do the free flaps or PMMC?
Most of time free flaps are done.
Okay, very good. Sir?
Now tell us about the neck dissection. He was clinically N0.
Yes, sir.
What will be the extent of neck dissection now, Rakesh?
So in clinical N0 necks, there is in on oral cavity, particularly buccal mucosa. Indications are for selective, that is supraomoid neck dissection, level 1, 2, 3. So we will go for that.
And what is the possibility that you may leave behind lymph nodes at the levels 4 and 5? What is the incidence of skip metastasis?
Sir, if the level 1, 2 are negative, then chances of skip metastasis to level 3 and 4 are very less. Initially, by studies like Byers and all, it was shown in very high percentage, but then later studies by Gurmeet sir et al. From Tata, they showed that if level 1, 2 is negative, then station 3 is 1.3 and station 4 is just 0.3 percentage skip metastasis.
सुप्राओमोहॉइड में 1 2 3 निकालते हैं ना?
यस सर.
तो 1 2 क्यों कह रहे हो? 1 2 3 अगर नेगेटिव है तो व्हाट इज द चांस दैट लेवल 4 and 5 will be positive? That is what he's asking.
4 is point like minimal, so 0.3% and 5 is even less.
Not so less. Is it 3%, 3 to 5 or what? Sir?
It is very low. I think it is particularly in buccal mucosa, if level 1 is negative, then the chance that level 4 or 5 will be positive will be very low. I don't know I think it's around 3% or even less.
So Rakesh, what do you expect from the pathologist? What do you want the pathologist to give you information?
So pathologists are first about the histopathological diagnosis along with the margins in all 3 dimensions, along with the adjoining adverse factors like PNI, LVI, worst pattern of invasion, and if there is some node, then extranodal extension. All these things, worst pattern of invasion should be mentioned so that in adjuvant can be decided in a better way.
What is worst pattern of invasion? What is worst pattern of invasion 5?
So worst pattern of invasion 5 is a type of soft tissue infiltration by the leading edge of tumor, in which the tumor grows like in form of satellites separate from the tumor, separated by millimeters, like more than 1 mm, in form of buddings or satellites from the leading front.
Presence of satellites.
Yes.
WPOI 5.
Yes.
Okay. तो ये आपको मालूम होना चाहिए. Which is more significant, the intratumoral PNI or extratumoral PNI?
Sir, extratumoral PNI is more significant.
Anything else you should expect from the pathologist?
Sir, LVI.
All right, LVI, PNI, and then WPOI. Anything else?
Then, sir, margin, of course, and
don't say margin, of course. Margin is extremely important.
yes,
and
sir,
on all sides,
three-dimensional.
You should actually ink it differently on all sides or put marks, and the pathologist will tell you which side you have got how much margin. That is more important.
Yes,
Because you will, in such situation, you will tend to have positive margins. You may get positive margins. So you should always either ink it or tag it. ये वाला इंटीरियर है, ये पोस्टीरियर है, या ये अपर है, लोअर है, तो ये जरूर टैग करके भेजना चाहिए पैथोलॉजिस्ट के पास. और ग्रेड ऑफ ट्यूमर इज आल्सो इम्पोर्टेंट.
yes,
then the surrounding mucosa, sometimes you find dysplasia, maybe moderate dysplasia, severe dysplasia at the edges. So you should ask your pathologist what are the changes at the margins. Okay. And then if you have cut the mandible, what is the condition of the mandible, edges of bone, marrow involvement is there or not, you should ask.
yes,
Okay. और स्किन साइड पर आपको एडिक्वेट क्लियरेंस मिला है या नहीं, that is also important. It is not just mucosa but also on skin side.
yes, sir.
In the lymph nodes, what do you expect from the pathologist?
In the lymph nodes, sir, we expect first is the lymph node is positive for METs or not. If it is positive, then what is it like? It is ITC, it is micromets, macromets, or is there any associated extranodal extension as well?
Other important things are number of nodes,
yes,
level of lymph nodes. Okay.
yes,
And of course, what you said, micrometastatic disease or obvious metastasis, extranodal extension, and any soft tissue deposits, if they are there, they should be mentioned. Okay.
okay.
When will you do a full neck dissection, comprehensive neck dissection in a cheek cancer?
When when there is n positive cases, right? Like on clinical examination, on imaging, we are having high suspicion of involvement of nodes, then definitely we will go for comprehensive neck dissection.
So when you do a supraomohyoid neck dissection in a T4
yes,
disease, will you do frozen section on the lymph nodes that you are removing?
Yes, sir.
And if it is positive, then?
If it is positive, then we will further extend the dissections.
If they say that only the level 1 node is positive with no extranodal extension, will you still do the level 4 and 5?
If it is 1B isolated, sir, then there is no need of doing level 4.
Will you radiate the full neck in your adjuvant? You are going to give adjuvant treatment to this patient?
Yes, yes, sir. It is T4 case. We are going to give adjuvant RT at least, and then depending on other factors, we can also add chemo to RT.
So how much of the neck will you cover in the radiation therapy?
Full neck mostly is covered, sir, in radiation therapy.
Even if it is N0?
If it is N0, yes.
Even then?
Yes, sir.
And what is the real risk area that you will want to cover, that you will want your radiotherapist to cover in the field of radiation therapy? Is it neck or is it some other area that you will be more concerned about?
Tumor bed, sir.
Tumor bed, yes.
And
I would be more worried about the superior extension of the disease towards the skull base, then into the neck. If histologically the nodes are negative, if the pathological staging is N0 also, then I would be more inclined to cover less of the neck, but cover the infratemporal fossa. Would you agree with me or no?
Yes.
I don't know whether your radiotherapist will agree, but really, as a clinician, as a surgeon, this would be my concern.
Yes.
Because the perineural spread will go towards the skull base.
Yes.
And there is a limit to how vast a field of radiotherapy you can give, how much they will tolerate. So if I have to cut out something, I would rather cut out part of the lower neck, but extend the field to the ITF.
Okay.
We as surgeons do insist on covering the upper portion till the skull base, but our radiotherapy colleagues, they never leave the lower neck. I don't know why, even if it is N0 neck, they tend to cover the whole neck. Am I right, sir?
Yes, yes, you need to really talk to them and let them understand really what the problems are. And if you see the recurrence patterns also, if you had an N0 neck and you've done this properly performed supraomoid neck dissection, very rarely will you get neck recurrence. More recurrences will be into the soft tissues and into the towards the skull base. So that is the area that we need to really cover well.
Rakesh, one quick question in histology. What are the histological types of squamous cell carcinoma? You talked of malignancy morphological types. So what
Yes,
are the histological types of squamous cell carcinoma in oral cavity?
histologically,
So that you tell us also about whether you will add chemo or not. You first finish Sir's answer.
so squamous cell carcinoma can also have component of sarcoma in itself. So it can be carcinosarcoma as well at sometimes.
Okay, just a quick revision of your histology. It could be verrucous, basiloid, papillary, acantholytic, adenosquamous, and sarcomatoid. Okay, just
Yes.
remember your pathologist might give different terms. They might use different terms. And now let us go on to the sir's question. When will you add chemotherapy?
So if there is margin positivity or extranodal extension, then we are definitely going to add chemo with radiation therapy. And along with there are some soft indications like low level neck node involvement, LVI, PNI, T3, T4.
LVI, PNI are not indications for adding chemotherapy.
Yes, sir. They are not significant, like based on EORTC 22931 and RTOG 9501, sir. Only proven indications are positive margin and extranodal extension.
And other indications, as you are saying, lower node dissection and
Yes.
Lower node positivity
and sir, if the primary is T3, T4 or multiple neck node levels are involved.
We are talking of nodes only. In nodes, extranodal extension, margin positive, fine. Chemotherapy कब add करेंगे?
Extranodal extension and margin positivity is
lower
the
neck nodes
and lower neck node. Yes.
And multiple level nodes.
Yes, sir.
Multiple nodes sometimes people include. Okay.
Yes, yes, sir.
तो ये सब इंडिकेशन हो जाती हैं फॉर एडिंग कीमोथेरेपी टू द adjuvant radiation. Okay.
Yes.
When
yes.
will you give NACT?
NACT is given in borderline resectable cases, like if a carcinoma tongue is reaching up to the vallecula, or it is reaching up to the hyoid, or if the CA buccal mucosa is going into high ITF, or there is diffuse skin involvement up to the zygoma, or if there is sometimes in carotid encasement also we try, like if it is up to 180 degree, then we can also give NACT.
Do you make a distinction between neoadjuvant chemotherapy versus palliative chemotherapy? you make a distinction between them. I think some of the points that you mentioned were not really neoadjuvant chemotherapy. They're just palliative chemotherapy. Carotid is close, high ITF is involved. These are all palliative chemotherapy.
NACT
Borderline
is
resectability is you will give neoadjuvant.
Yes.
To make it resectable.
Yes.
Okay.
In unresectable cases,
indication है that is mesenteric space involvements, or you are saying yourself high ITF, suprazygomatic area में edema पहुंच रहा है. ये कुछ लिमिटेड इन्वेस्टिगेशन लिमिटेड इंडिकेशंस होती हैं जिसमें NACT का रोल है.
yes.
Otherwise, as sir is saying, that it is basically palliative.
Yes.
I think if our time is up, all I can say is that Rakesh, you are really good. I think you're really good. I think you have presented the case so smoothly. There is no coming in between. And this should be the quality of presentation. And you've also defended all the questions very well. I think you've done extremely well.
Thank you, sir.
Wish you all the best.
Thank you, sir.
Well done, Rakesh, and keep it up. Exam nazdeek aa rahe hain.
Thank you, sir.
As Dr. Somsekhar pointed out, that oral cancer you are going to get in exam. So you must prepare it well.
Thank you, sir.
Okay. Thank you. Well done. Dr. Somsekhar?
Yes, sir. Fantastic, sir. Sir, heartfelt thanks to Pradhan, sir, and Diwan, sir. Fantastic. Actually, a good candidate like him is not good for discussion for other candidates. We want them to make mistake. You can bring any answers, everything. It's so smooth, as Pradhan, sir, told. But very nice. Rakesh, superb. I'm really happy that too, in Cancer Samstha, the 99% of the patients are oral cancer, and you have mastered it. Very, very smooth presentation. I really liked it.
Thank you, sir.
Thank you. Pradhan, sir, and Diwan, sir, thank you very much, sir. As I always say, we can't give anything to you where both of you have everything. We can just give blessings from students, DNB board, and myself for taking time out in busy day, coming and helping students, sir. Thank you very much for all the help, sir.
Thank you.
It has been a proud privilege for me also. I was student of Dr. Sultan Pradhan.
Oh, so
I
sweet.
under him in 1989, and
Wow.
I think I just can't forget the art of surgery and this masterpiece.
Fantastic.
Nice to see him operating. I still remember those days.
So
And,
nice, sir.
Meeting him after a long time on the screen.
Likewise.
Sir,
Thank
thank
you.
you.
Thank you very much.
Thank you, sir.
Thank you. So over to you, Yuraj ji.